Hi, my name is Rohith. I'm here with Alice. We're the co-chairs of the Rochester campaign for New York Health. It's great to be here. Thanks for having us. It's good to see so many progressives out of a meeting like this. So I'd like to start with just telling you a little bit about myself and why I support this issue. So I'm a medical student, and I've seen patients that put off care because of costs, doctors having to alter prescriptions because their patients can't afford their drugs, doctors arguing with insurance companies for hours on end, and we all want a system that works for us, that puts patients first, that prioritizes our well-being and not the financial well-being of insurance companies. And so that's kind of what brought me to this work, and thank you. To that. And because I think kind of the human element of this is really important, I'm just going to start out with a short video, like one case study of an individual interacting with this, with our current for-profit health system.
Yeah. 5 years ago, I might have had a possibility for a cure. My name is Sarah Bednarik. I have stage 4 cancer. I'm on Medicare, and I'm an artist. I had no Medicare before I became sick. I think it was about $1,000 a month for somebody buying it on the open market, which was just too much. So I hadn't been to a doctor in about 10 years, and it happened gradually. I at first didn't really notice, but I began to start cutting things out of my diet because I couldn't poop. I thought I had food poisoning because I was vomiting a lot. So the people I lived with, my friends, they made me go to the emergency room after it turned out that my intestines were blocked. And then they didn't know what it was. So they had scheduled a colonoscopy. They started asking me for money like almost as soon as I was conscious, and I didn't have any, and they sent me a social worker to be like, how are you going to pay us? And I was like, I don't know. The hospital sent me a lot of bills. Like, I think the first one I got was like $57,000. The amount of money that it costs to treat cancer is astronomical. Unless you're like a billionaire, there's no way that you'd be able to easily afford cancer treatment. My mother had arrived at that point, and through her really hard work, actually, she managed to get me signed up for Medicaid, which was necessary. Once Medicaid kicked in, then all of that just went away, and they paid for it. No one tells me which doctor I can go to. My oncologist has saved my life 3 times now, and the idea of maybe, for example, an insurance company telling me I can't see her anymore, that's awful. A lot of times my friends, for example, will get huge bills, or they just won't, they won't have met their deductible yet, and they'll be paying out of pocket for all of their whatever it is they need, or they'll avoid going to the doctor at all because they can't pay the deductible. And that's not the case with Medicare or Medicaid. If the New York Health Act is anything like Medicare, which it is, it would help the public so much because they wouldn't have to deal with the kind of stuff that I haven't had to deal with for a while. Everybody should have that ability to make the right choices for themselves and not have some sort of corporate interest making those choices for them.
Right, so again, we're the Rochester campaign for New York Health, and we're going to tell you about the New York Health Act that Sarah in the video did earlier. I just want to start by acknowledging our close partners that we work with, and they include PNHP, who I got some of the slides from, Metro Justice, Nurses Association. In Rochester, we work very closely with Rock Citizen and Rock DSA to get the word out about the New York Health Act. So the one really important thing is that we say healthcare is a human right a lot. In academic circles, I often hear people say, oh, what even is a human right? How can you go around saying that healthcare is a human right? But actually, in the UN Declaration of Human Rights and in the New York State Constitution, it says right there, everyone has a right to a standard of living adequate for the health and well-being, their health and well-being, including food, clothing, housing, and medical care. And the New York State Constitution also has a section that starts with that the government shall be responsible for the protection and promotion of the health of the inhabitants of the state. So I feel very justified in using that phrase. I feel we should be very confident saying healthcare is a human right. It's something we all deserve. It's something that arbitrary companies should be able to take away from us. And so this is a schematic of our very complicated and inefficient current system in which the government as well as the people, us, give money to both insurance companies and public insurance, which then either pays doctors and hospitals' offices or wastes it on administrators and trying to keep people from seeing their doctors, or in giant checks to insurance executives or an insurance company profits, and then some of the money makes its way to doctors' offices and hospitals and actually creates healthcare for us. And under a single-payer system like the New York Health Act, businesses and people would pay income-based progressive premiums to a public insurance pool, the government, which would provide insurance for everyone to see any doctor or any hospital. Simple. And now I'm going to turn it over to Alice to talk about the detail of the bill.
Right. There we go.
I have a video first, actually.
Video. Video.
This is kind of an ad summarizing the bill.
There's an epidemic that millions of New Yorkers and people across the country are suffering from, and you may be suffering from it too. It's private insurance-induced stress disorder, PIISD, or PISD. When you get a bill in the mail that your health insurance premiums have gone up 20% or more, or when you realize you have a 50% co-insurance even after meeting your deductible of $3,000, or when you don't have insurance at all because you can't afford it, or when your insurance plan drops your doctor and you have to find a new one, or after spending countless hours on the phone arguing and pleading with customer service after you've been denied treatment. It occurs after your bank account has been drained of your life savings to pay for care, or after seeing a loved one maimed or die from an otherwise manageable illness. But there is a cure, and that is the New York Health Act, guaranteed health care for all of us. The New York Health Act eliminates wasteful private insurance companies and replaces them with one public program that is accountable to us, the people. We can have an improved Medicare for All-like plan for New Yorkers. Healthcare that covers everyone as a right, as a public good, not as a commodity to be bought and sold on the marketplace. The New York Health Act would cover all medically necessary care, including vision, dental, mental health, reproductive health, prescriptions, and long-term care. 98% of New Yorkers would save money on healthcare. It would be funded fairly with a progressive tax based on your ability to pay, instead of forcing people to pay as much as possible and go bankrupt in order to get life-saving treatment. It will restore decision-making to the doctor and the patient, not the insurance company bureaucrat. The New York Health Act has passed the Assembly 3 times with huge majority support in the last 3 years. We only need one more senator to have the majority of the state Senate. How are we going to get across the finish line and make this a reality? You. We know the opposition is formidable. They have serious power and money. But we have the people. We need to win universal health care so that everyone can have the peace of mind that they and their loved ones, their neighbors, and their employees get the health care they need when they need it, without fear of going bankrupt. Join the fight and make sure that New York does the right thing. Call your state senator today. Tell them to support the New York Health Act, guaranteed health care for all of us. Sign up at nyhcampaign.org.
Now I'm going to turn it over to Alice for more details.
All right. Let's see. I will take this. Remember which one to push. All right. I'm a library conservator, by the way, and you'll hear one little bit more about why I'm supporting this myself a little later. But the question right now, New York Health Act, 2018, any Republican, not only any Republican, any responsible legislature later in New York is going to be asking this year, okay, but how do we pay for universal health care when the federal government is in the process of slashing healthcare funding for states? There are answers to this question contained in the Act itself, and I'm going to zip through the content of the Act right now. So you'll be seeing a lot of slides full of text kind of flying by. My contact information is on the flyers that we brought, and there's a few more at the edge of the table, if anyone wants a copy of the PowerPoint. First of all, it's worth noting that New York currently sets the pace in healthcare spending by a long sprint, not in a good way. We clearly are spending a lot more per patient than any developed country. These are all other countries. Here's the USA. Here's New York. Particularly those offering single-payer care. Here's a brief outline of why, taken from a very interesting book on the subject published this last year. You can ask your senator if he or she has read it. Note that the list doesn't directly mention the insurance middleman. Elizabeth Rosenthal is a doctor. She was going over things that she has seen in her practice, or through her practice. So when someone says, well, single payer won't solve the problem, however, the rejoinder is, yeah, but it will make it much easier to solve them if it is done correctly. Here's our bill, which attempts to do it correctly. Besides working to get it enacted, we need to work to keep its focus from being diverted away from effective healthcare and back towards profits for powerful stakeholders. This is going through Albany. It's well worth checking out the bill as it stands now and getting to know it. The number will be changing as soon as it's renewed for 2018, which is why I have a 2017 number 4840 in blue, it was. But it should work fine for a Google search for now. Those numbered lines, 1 to 9, are the first actual 9 lines of the bill, by the way, and I love how it gets right to the point. Oops, I wanted to use something else. Yes! There we go. The rest of section 2, section 1 was the title, by the way, describes the problem of rising healthcare costs and outlines the creation of a single New York fund cobbled together from all the current federal, state, and state sources as the basis of a single-payer system that will eliminate private health insurance. Each bullet point here represents 1 or more paragraphs in the bill in the order in which they appear. Movement away from fee-for-service is the first hugely important piece of lowering cost. In the bill, it is merely promoted, not mandated, but at least it's there. Later, we will get to how that promotion can actually be effective. The employment benefit, the fact that employers pay towards employees' health care, is left in place in this bill. So being employed will still give significant advantage for cost of care, and the people most likely to be affected negatively are those who are well-to-do and self-employed or make significant income from dividends and capital gains. The collaborate versus compete section is interesting. Republicans tend to favor free market competition and assume it will drive down prices, but in fact it can contribute to inefficient siloing and duplication of services. Article 50 of the New York Public Health Law is the closing verbiage of the law. So by this bill, it gets renumbered as Article 80, I suppose, in order to leave space for other future additions. But all of what's going to follow in this section 3 is proposed as Article 51, additions to the existing public health law. Section 3 starts with a big list of terms like board, coordination of care, resident, participating provider, and so forth, and goes on to outline how the transition from current multiple source insurance to a single payer system will be done. The composition of the board that figures this all out is one of the most specific sections of the bill. All the board members are Albany appointees, which is scary, but the appointments are spread around and there is a laundry list of stakeholders. All of this is keep pressing one thing, is required. You notice that patients aren't listed as a stakeholder group, and you think, well, what were they thinking? But since every board member and all of the state representatives appointing them will be covered by the new system, they will in fact belong to that group. Everyone on the board will be a patient. One item specified back in section 2 is that there is to be no other source of coverage. And here it specifies that the board will be covered under the plan. The people who make the decisions will have to live with them. Here, the benefit package is spelled out in very general terms. One concern with universal coverage is that if everyone gets the care they need, it will cost too much or there won't be enough doctors to go around. I do want to take a minute here. Show of hands. How many people in this room would have gone to a doctor within the last year but could not get an appointment? Okay. Yeah, 2 hands. All right. How many decided not to visit a doctor in the past year because of the cost? Bunch of hands. Yeah. How many went to the emergency room because they don't have insurance or a primary care physician? Nobody in this group, but that certainly happens. That's all food for thought.
She's got something unique.
I mean, I went to urgent care because I don't have a physician where I live.
Yeah. Yeah. And urgent care is actually pretty nice, but in any case.
Yeah.
Yeah, I mean, it's a good stopgap measure, but there's
But
better.
it still costs money.
Healthcare costs money. Care coordination is, however, one way to save on healthcare. When you have someone making sure that different providers for different health problems are all talking to each other, you get better care and you also don't have so much occasion for tests done twice and other unnecessary treatment. And the designation of standards for care, let me see if I can get that green, yeah, that one, is also key to the success of the plan. Once you have government involvement in contracts, the topic of accepting the lowest bid will come up, though it's not mentioned in the bill. And in that atmosphere, having all contenders held to the same standards and having those standards be adequate for good care is crucial. Finally, if the department makes available the information regarding care quality, cost, and outcome that is required of providers in order to remain in good standing, that alone will make an enormous difference in reining in costs, since it is the obfuscation of that information that lets providers at all levels charge for unnecessary care. There is provision for this, and we'll get to that later. Here's another very meaty section. Once again, with most of the meat left up to that 26-person board to determine. Most of the savings that would make it possible to cover all New Yorkers would result from savvy and transparent negotiations, experimental payment methodologies that make health, rather than treatment, the central commodity, and hawk-like interest amongst the legislature and the general public in cost effectiveness. That's us. One of my interests in having a government as the single payer is that some negotiation details would be open to FOIA, Freedom of Information Act requests, and that healthy taxpayers will have a stake in pursuing cost effectiveness while they are healthy and can think clearly. I think both of these should obtain with this bill as currently written, but I haven't seen any accounting for them in analyses of cost, which is interesting. And success here does depend heavily on citizen involvement. This is, after all, Albany. All three of these, capital expenditures, medical, I'm not gonna, let's see, is that, no, next one. Yeah, no. There, yes. Capital expenditures, medical education, and out-of-state and therefore out-of-network services are all important. Perhaps especially the medical education, given the problem of insufficiency of primary care staffing. All of this is mentioned pretty generally, however, and all, again, up to that big board to figure out in detail. Let's see. Where are we? 3510607. Okay, oh, note that the requirement for simplification and transparency, etc., so desirable for quality and cost-effective care, is specified here in relation to standards for providers in order for them to maintain their licenses. I do not yet know how much of this already exists on paper in current law. Once again, a lot rests on that board and on citizen involvement. Here's what I like to see though, a direct statement that payments will not be calculated to accommodate profit, and even more importantly, that all providers will permit examination of records. And here is where the fact that that big board includes a cross-section of stakeholders and is directed to consult all interested parties can make it accountable. This could get us to the kind of transparency needed to see whether we, as supporting taxpayers, are getting what we're paying for, which, as insured parties, we have currently little way to do. We need to keep this in the bill. There's a long discussion in these sections of what kinds of intervention could be needed if, for instance, just for instance, the federal government refuses to allow the state to pool Medicaid money and instead requires individual Medicaid billing per patient and treatment as is done now. This would add a big layer of bookkeeping and necessitate not only that all Medicaid treatments be billed to the federal government as now, though the provider payments would be larger under the program probably, but also that all Medicaid recipients specifically agree and direct by contract that New York Health Act program receive the federal payments for their care. If they do not agree with this, they would have to remain on standard Medicaid and not be members of the Health Act. That's what I mean by messy. If Medicaid goes to block grants, however, the mess goes away, though the money may be reduced overall. In this regard, the contracting of nonprofits to provide help with initial enrollment is quite important. The funds for retraining former insurance employees are also quite important, since the insurance companies employ roughly 300,000 people. The Friedman analysis that I will get to shortly notes that many people currently employed as billing specialists actually have medical training. There's just more market right now for billing specialists than practitioners, part of the current sick system. Meanwhile, the data collection is actually another important point regarding not only promoting health, but also promoting cost effectiveness through tracking health outcomes. Price tag unknown, but the return on the investment is likely to be quite large. The regional advisory councils are an interesting and potentially very important inclusion. The fact that the meetings are required to be public and to report on regional plan evaluations is an important means of transparency, since the reports prepared for the purpose of negotiation at the state level are specifically protected from FOIA requests. That's one interesting thing, and it's kind of necessary actually in tricky negotiations. So here is where the transparency can and must happen. Regional provider payment methodologies will include some provision to provide for, but not exaggerate, geographical differences in actual cost over the state. And here at the regional level is where the information on the quality, cost, and outcome should reach the general public. Yes. Even if a requirement that this information be published in an easily accessible manner is not included in the bill, and I haven't found it, it must be reported and evaluated at these regional public meetings, where it will be accessible to the type of citizen organizations that are already publishing such information. Okay, deep breath. Financing for all of this. If the bill is enacted, the governor has a year to come up with a proposal for it in the executive budget. And I will note at my last visit, my state senator said, well, this needs to be in the executive budget in order to bring it up for a vote. That's the answer to that. It's the executive budget is required the year that is decided on. And here comes the new tax that pays for everything and substitutes for the premiums, deductibles, copays, co-insurance, and out-of-pocket payments that we're currently making for healthcare. This is what opponents of the bill say will be too high and will drive wealthy, healthy people out of New York. Note that this is partly because the tax will be progressive. That is, richer people will have to pay a higher percentage, just like with income tax. The bill does not actually direct how much that tax will be, what percentage, or how progressive. But there is no question that healthy, wealthy people will end up paying more for healthcare than they are now. The question is where that line between those who will pay more and those who will pay less will fall. The rosiest of the analyses estimates that 2% of New Yorkers, yeah, you know that 2%, will pay more than they are now, and the rest of us will pay less. The opposing analyses do not suggest specifics, they just say it'll be more than we would like to believe, and more than high-income residents will be willing to pay. The devil will be truly in the details, so we need not only to get the bill passed, but also to keep it honest. That's why the sunlight provisions mentioned above are so important. Here are details on transition, including that employment benefit mentioned earlier, direction that it has to deal with phasing in the program and covering special situations, and that bit about taking over what local municipalities have been paying for Medicaid. Can I do that? Medicaid, yeah. That would make a huge difference in property taxes, of which Medicaid is often a big component. And that's why that was floated as a provision of the American Health Care Act at the federal level. Remember that? Yeah. Well, this will do, in fact, the same thing, only spreading the cost more equitably. So this section, regulations regarding the bargaining process, is added to the existing public health care law just before the big overall program description from section 3, so it's in Article 49. The authorization of collective negotiations allows providers to bargain in groups through representatives, though the state can also negotiate with individual competing providers. Paragraph 4296, labeled confidentiality, requires that reports required by the department for the negotiations will not be subject to the Freedom of Information Act. That bears further research, which I have not yet done. These sections relate to cost containment. In Section 6, the New York Health Act replaces the Family Health Plus program as a state public health plan in the section on deferred drug and clinical drug review programs. It looks like this means that under the New York Health Plan, a doctor would need to show cause for prescribing a non-preferred drug in the way that they would need to do so for Medicaid. This could be important and could use more research. And then Section 7 describes the watchdogs. Sections 8 through 10 have more details about making the transition immediately after the act goes into effect. It would be nice to have a single trustworthy analysis of the likely result of the enactment of this bill. But what we actually have instead is two, actually probably multiple analyses. One prepared by a longtime proponent of single-payer healthcare, and another by a writer for a right-leaning think tank. Not surprisingly, they come to very different conclusions. The New York Health Act bill describes the payroll deductions used to supplement the pooled federal health care money as premiums. And they do, in fact, take the place of premiums and deductibles and copays and coinsurance and so forth. But they are automatically deducted from wages or billed at tax time, like taxes. And yeah. And let's see. Friedman is an economist from Amherst who in 2015 did an analysis of the bill, and that you can get online through the New York Health Campaign site. And here is his suggestion as to how you might set premiums.
What's his first name?
Gerald
Gerald Friedman.
Gerald Friedman.
I'll keep it from Tom.
Yeah. No, different one. All right, and here is a table I put together showing how that translates to monthly premiums for people at different proportional levels of income within the actual population of New York State. In other words, the top 1% would be paying, if they're an employee, monthly $854. If they make their $383,000 per year from mostly capital gains, they'll be paying $4,000 a month. For a more concrete example, I currently earn $52,000 a year as a library conservative conservator at the U of R. According to Gerald Friedman's recommendation on the progressive payroll deduction required by the bill, based on his analysis, me and the U of R, between us, total, would pay nothing for the first $25,000 of my income, of what they pay me, 9% of the next $25,000, and 11% of the top $2,000, for a total of $2,470 a year. My share of that would be $494 a year, with the U of R owing $1,976. So I would expect to have $41.16 deducted from my paycheck each month. As my full payment to replace my family plan, that would be amazing. I currently pay, all told, out of my $52,000 paycheck, $6,000 a year, $500 a month, for my family plan, because we tend to reach, in my family, this is because we reach the out-of-pocket limit, which the U of R package is quite generous. It has, I'm lucky enough to work for a university that includes a teaching hospital. My husband has a heart condition, my daughter is depressed chronically, and I had breast cancer this year. So, $6,000. And I feel so incredibly lucky that all I had to pay this year was $6,000. And meanwhile, my employer has paid $15,412. So I would save over 90% of what I spend now, and my employer about 87%. Meanwhile, a married couple, each of whom is a well-paid administrator earning, say, $250,000 a year, would now, instead of sharing a family plan similar to mine, owe a monthly premium of $500 each. I could see why they might be a little ticked, especially if all or part of that income were from dividends and capital gains, which they don't split with their employers, who would owe $2,000 monthly, like I said. Now we begin to see why this plan is making slow headway amongst wealthy capitalists. Think about the people on Wall Street who earn millions in capital gains each year. Those figures would make one's head go round and round. You can hear my tiny violin playing. But at the very top, this is pretty serious redistribution of income. And that is assuming Friedman's cost figures are more or less accurate, which the right-wing hack jobs roundly dispute. Okay, let's say that Friedman's estimate is totally off of the total cost, 100%. And so then let's say we decide to give the very top earners a break with a cap of $1 million a year or something like that. So that, say I, the 50 percentile earner, well, I might have to pay like 3 times what Friedman estimates. Oh, wait, that's still a third of what I'm paying right now. So to recap, pros and cons. Replacing for-profit insurance and negotiating with providers, drug and device companies from the basis of considerable strength of numbers is explicitly in the bill, as is a public accounting of healthcare quality, cost, and outcome on at least a regional basis. Replacing the current payment model of single or family plans with deductibles and copays with one that spreads the cost across the ideal insurance pool, 100%, means that people who pay the most for healthcare will be those most able, instead of those least able to afford it. I consider that a pro, though healthy, wealthy people will certainly pay more. No matter how the negotiations with providers pan out, it will mean much simpler billing for them, which is why many doctors and even more medical students are very excited about the bill. Less time bickering with insurers means more time treating patients. The bill also explicitly includes coordination of care and experimenting with alternatives to fee-for-service payment during the negotiations with providers. All of those factors will tend to lower absolute costs as well as distributing them more fairly. On the other hand, passing this bill will put us on the cutting edge, aka the bleeding edge of U.S. healthcare funding. The right-wingers say that, I think his name is Roy, says that Friedman overestimates savings due to administrative costs and underestimates the effect of sick people deliberately moving to New York. Like I say, I wouldn't mind paying twice as much as Friedman's, 3 times as much as Friedman's estimate. Also, Friedman has given pretty good answers to a lot of the right-wing comments. But if you have not paid anything previously, or if you were in an upper, that is, you haven't had insurance have been fortunate enough not to need it. Or if you're an upper income bracket for whom 10% of income for healthcare is still a rude shock, I could see reason to worry. Hammond was one of the right-wingers, also raises the question of, this is Albany we're talking about, right? The bill does include a lot of oversight. The comptroller is in charge, community and healthcare representatives, regional public hearings 4 times a year. And there are other ways to keep sunlight shining on this. Forewarned is forearmed. But the question is well worth asking, and there is no doubt that some unscrupulous and wealthy providers will be actively looking for ways to game the new system, including old-fashioned graft. The question of employment upheaval is also one of the big issues that kept single-payer out of the US for so long, across the country, and it is specifically addressed in the text of the bill. Friedman notes that medical insurance accountants have very transferable skills, and some already have medical training and will be needed as additional care providers, in some cases in the very facilities where they already work. And I would note that savings and certainty regarding employer premiums will also spur job growth in other areas of the economy, which but upheaval will be there. Here are the unknowns that have so far kept a single Republican senator from co-sponsoring the bill, and will no doubt keep that 26-member committee up at night. My own personal opinion is that the opportunities for transparency and accountability offered by the bill outweigh the risks, given that we already know that the current system is untenable and have yet to see any more free market friendly legislation that even begins to address those rules of dysfunction outlined by Dr. Rosenthal. But I can see why it's a scary step to take. And I say this because it's what we're up against. I'm here because I'm certain that the New York Health Act is not only the best way available to guarantee the acknowledged right of all New Yorkers to adequate health care, but is also the best way to make health care affordable to everyone in the state. But in order to convince Republican senators fresh from passing a horrendously difficult budget, you may have heard this, we will need to muster overwhelming public support. So, back to Rohith. I will do that.
Thanks, Alice, for that excellent summary. So I'm just going to talk briefly about the political situation and what we're doing to try to push this bill forward here in Rochester. So as I'm sure everyone in this room knows, Rochester is and our region is terribly gerrymandered into 4 or 5 different Senate districts. So we've been focusing our efforts somewhat on Rich Funky's district because we think he's a senator that can be picked off. But frankly, there should be no Republicans representing us. So this is a bad situation where there's lots of Republicans who just like to say to us that we're being unrealistic, that the people who work for insurance companies, their jobs are more important than people's health. And so we're trying to overcome the resistance locally from politicians. But the way to do that is to build a popular movement by telling people about how great the New York Health Act is, how we all really need single payer and Medicare for all to make us healthier and make our lives better. So we've had a few events, and we'll tell you a little bit about the canvassing we do. But we try to do more creative things, like on Medicare's birthday, we handed out cupcakes and told people about the success that these public programs, Medicare and Medicaid, have had, and about the single payer. We're here with our happy birthday flyers. And then every year, everyone across the state, all of us advocates go down to Albany and lobby our state senators and representatives. The first year I went was 3 years ago now, 3.5 years ago now. That was the first year it passed the assembly since 1992. And it had been continuously reintroduced, and now it's passed, as Alice said, 3 years in a row, 2/3 majority in the assembly, and with one senator co-sponsoring away from a majority. So we'd love to have people, especially that have healthcare stories to tell, to come with us to Lobby Day, and really have their voices heard. We have a big rally in front of the state capitol. When the
Do you know
yes.
when Lobby Day is?
Not yet.
Yes,
Okay.
yes, yes.
Oh, we do?
We just, I don't know off the top of my head. It's in May. It's
Good.
in the
'Cause
third
it's
week of May. I can check my calendar and tell
Well,
you.
we need a bunch to understand on stuff.
Yeah, I have it in my calendar.
Okay.
It was released like a week and a half ago. Any other questions? So this is a silent protest. We kind of had a funeral procession for the ACA when the Senate voted to debate the AHCA. I think this was very successful. This was fun because we did it in Fairport. People in Fairport aren't used to seeing people carrying healthcare as a human rights signs. And so we blocked up a lot of traffic. Some people were angry, but I think a lot of people saw our messages, were honking their horns. Very happy. And so here's how you can get, so let me explain our philosophy, what we've been doing since then. Is we want to reach out to the people that have been most affected by the for-profit health system and help them tell their stories. And so one of the primary tools for this is the Health Access Survey. I shouldn't call it a survey. The Health Access Conversation Tool. So we ask people questions about their healthcare, and it helps kind of structure a conversation so we can get to know them, we can learn their story, and then we can report it back to the statewide campaign, and they and then they put it into a report they're writing, and then also we follow up with these people, and we try to write down their stories so we can share them on social media, take videos. The people in New York City have set up a collaboration with the app called OnStack, where we can now take videos in real time of people just from our phones and start spreading those around. So we're really just trying to elevate the voice of the people that have been affected by the for-profit health system and really show the public why we really need single-payer healthcare. So here are the things you can do to get involved. If you are a super wonk, you can join the Wonk Club, which is led by Ted Brown.
What's the Wonk Club?
What they do is they get together, and every time one of these conservative think tanks funded, like the one Alice showed you, Avik Roy, he's a right-wing hack. He was paid, he has a think tank that's funded by the Koch brothers, who's specifically paid by the insurance industry in the state of New York to write a study against New York Health. So they went in and they debunked point by point what Avik Roy said. And they find out who sponsors these hack jobs, and then they debunk the hack jobs. And so that's really important work happening in Rochester. And then one very important thing is to endorse the bill, sign the petition, which we sent around petition sheets, the same thing, but as soon as you go to our website, the first thing that's there is sign the petition, put your name in here. Tell your friends about single payer. We gotta tell everyone we know, really convince them this is the right way to go and generate buzz. And that's how we're gonna win. Make it so there's lots of people that want this bill, and when it comes to the governor's desk, he can't veto. And you can come join us at our events. You can tell your healthcare story. We'd love to write it down, take a video of you, share it on our social media accounts, email it out to our supporters. Can help come with us to canvass in an underserved neighborhood. We're not doing that as much in the winter because it's cold. But we do canvass by phone, so we phone bank and call people who have signed petitions and ask them about their healthcare stories and try to bring them into activism and to collect their stories. And you can come to Lobby Day or one of our health committee meetings, which are on the last Wednesday of every month in Metro Justice.
We will also be setting up meetings with senators, because
Oh, yes. Yeah, and as the legislative session starts, we'll be setting up meetings with senators. And one of the really important parts of finding all these people with impactful healthcare stories is we want to take them to the senators' offices and make the senators talk to people that have been impacted by this for-profit health system and say, look, this is the person who you're screwing over by not acting on this issue.
Oh, I see all these slides going by, but is any of this on the flyer or is there
Yes.
separate?
they're,
Yeah.
yeah, it's on the flyer.
Okay.
The-
Alice's email address, as well as the information for this event in particular, is all is on flag.
Is the headcount in the Senate strictly by party lines? Is it?
Yeah.
There's one Democrat.
The
IDC is
is voting for
co-sponsored.
it. Yes,
There's
they're
one Democrat, Sincha Felder,
Who's on the other side?
who's on the other side. He caucuses with
So
Republicans
he
too.
changed the decline